Yeah, done.
Yeah, thank you. Uh, Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your questions in the comment box so that at the end of the webinar we'll have a short Q&A session. Now let me welcome our today's eminent speaker, Dr. Laxmivani Tellakula, who completed her medicine and DGO from Guntur Medical College, and she is a practicing in Laxmivani Hospital as a consultant gynecologist since 21 years. And she's a member of voluntary organizations, and coming to her special interest are in giving awareness meetings about women's health, also doing PCOS awareness programs and campaigns. So with this, we welcome you for today's webinar, ma'am. And today's webinar is streamed through the Shield Connect, which is a digital platform of Shield to connect all the doctors at one place. I request all the delegates to please do visit the Shield Connect. If you miss any part of the program, it will be available in the Shield Connect. And coming to the today's topic, as we know, PCOS is one of the most common causes of endocrine dysfunction in women of reproductive age, with a prevalence that ranges of 4 to 7%. And metabolic disturbances are well recognized clinical feature of this syndrome. Especially dyslipidemia is a very common metabolic abnormality in women with PCOS, and with a prevalence up to 70%. So with this, without wasting much time, let me turn over the time to Dr. Lakshmi Vani ma'am to talk on dyslipidemia and PCOS. Over to you, ma'am.
Thank you, Dr. Someshwar Garu. A very good evening to all my teachers, my friends, and all the delegates who joined in this session, and also Shield Connect people. First, let me wish you all for the coming Telugu Ugadi in advance. So today my topic is dyslipidemia in PCOS. So today I'm going to cover the topic PCOS. What is PCOS? Its pathogenesis, and dyslipidemia, associated hyperandrogenism, insulin resistance, anovulation, leading to metabolic syndromes, and treatment of dyslipidemia. So today PCOS has become an epidemic in India.
దగ్గర పెట్టుకున్నారు మైక్ ఒకటి దగ్గర పెట్టుకోండి మైక్
So today PCOS became an epidemic in India with the prevalence of 41% in overall India, with increase in urban areas than in rural areas. 1 in every 5 women is a PCOD patient, and now the burden of PCOD in India is 117 million. And now this was first described by Steen Leventhal in 1930. He described the association between the PCO morphology, hirsutism, menstrual disturbances, and obesity. So PCOS is the most common endocrine disorder in women, and its prevalence is 3 to 10% in the reproductive age group, with 25 to 30% in the infertility patients. And it is the major cause of anovulatory infertility. It constitutes to 75% of the anovulatory infertility. So, next slide, please. So, coming to the pathogenesis of the PCOS. So, there is exaggerated adrenaline in the childhood itself. Also, it is autosomally dominantly inherited, and then because of the genetic predisposition, There may be exaggerated adrenaline with increased androgens from the adrenal cortex. This leads to increased endogenous opioid tone and in turn the GnRH frequency of pulsatility leads to increased LHRH. In turn, pituitary is more sensitive to LH and leads to increased secretion of LH. This LH acts on the adrenal cortex, ovarian cortex, ovary to increase adrenogens from the theca cells. Also, there is increased activity of the adrenal cortex in childhood. These adrenal cortex androgens, they predispose the ovary to increase more of androgens. So, with this genetic predisposition and increased androgens, the ovary also secretes more androgens. So, there is pituitary LH and decreased FSH in PCOS. Coming to estrogen levels, estradiol levels is almost stable, but in estrone levels are increased because of formation from androstenedione by aromatase enzyme in the ovary and also in the adipose tissue. As the patient is more obese, more aromatase and more estrone is produced. This estradiol levels are free in circulation because of decreased serum hormone binding globulin. And so these serum free estradiol can suppress the FSH from the ovary. And then estrone increased, estradiol is stable. Progesterone is reduced because of the anovulating cycles. And also anti-Mullerian hormone is more in case of PCOS patients. This correlates with the hyperandrogenism levels. Also, AMH, it inhibits the primordial follicles entering into the growing follicle cohort, and thus it increases the lifespan of a PCOS ovary by 2 years than normal population. There is hyperinsulinemia. Hyperinsulinemia, it is because of the genetic and dietary factors. So there is insulin resistance also. This hyperinsulinemia, because of the insulin resistance, it can induce LH receptors on the granulosa cells. So premature differentiation of the granulosa, premature differentiation of the follicles even before growing. So there is follicular growth arrest. At the same time, insulin can stimulate the theca cells to increased androgen production. These in turn on liver leads to decreased serum hormone binding globulin levels. In turn increases the free androgen levels. And also insulin acts as an anabolic hormone to increase obesity. So all this forms a vicious cycle, and thus PCOS includes hyperinsulinemia and hyperandrogenism. Then coming to the etiology, it's a complex trait of genetic and environmental factors. There is two hit hypothesis: congenital predisposing hit, hereditary traits and gene variants affecting the ovarian function, metabolic traits and gene variants predisposing to insulin resistance, obesity, and type 2 diabetes mellitus. There is congenital virilization, disturbed fetal nutrition. In small for gestation and intrauterine growth retarded fetuses, there is thrifty phenotypes induction that leads to insulin resistance, increased cortisol levels, increased androgens, and increased adrenal cortex activity. And in puberty, they lead to PCOS with lifestyle as sedentary life and increased saturated fatty acid intake. Slide. So next slide shows the PCOS phenotype. All this, it's CNS program in utero itself with epigenetic changes and genetic variants and adrenarchy, inflammatory factors, environmental factors, lack of exercise and activity, hormone exposure at puberty, and then ectopic fat storage, adrenal factors, androgen axis in the adulthood, ovarian factors, insulin resistance, and insulin increased secretion. And in pregnancy, the neuroendocrine factors, they also play, in turn leading to PCOS phenotype. Main clinical and metabolic manifestations of PCOS according to woman's stage of life. Clinical manifestations of PCOS may be seen after puberty, but the program is done in utero itself. Next slide. So major characteristics of the PCOS phenotype according to the age. In childhood, there may not be features that are manifested, but history of close relatives having PCOS, and mother may be having gestational diabetes mellitus in pregnancy, and the baby may be of low birth weight or increased catch-up growth. In early adolescent phase, there may be early menarche with irregular menses, hirsutism or acne, overweight or obesity, increased testosterone, and increased LH. Mild metabolic abnormalities may be seen. So in this age group, a long-term follow-up is needed because irregular menses, PCO morphology, and also increased androgen levels may be physiological. Ultrasound may not be diagnostic because multiple small follicles, they are seen in the active ovary at this age group. In the late adolescent stage, there may be irregular menses, hirsutism, acne, persistent hyperandrogenemia, overweight or obesity, and metabolic alterations may be there. In this age group, persistent oligoanovulation in presence of hyperandrogenism, either clinical or biochemical, strongly suggests the PCOS. Also, ultrasound findings of PCOS may support the diagnosis, and obesity at this stage should be considered. In the adult fertile age group, there is hyperandrogenism with manifestations as hirsutism, acne, and amenorrhea. Irregular menses, particularly oligomenorrhea, may be biochemical increase in the androgen levels, leading to hyperandrogenemia and infertility, overweight, or obesity. Features of metabolic syndrome with type 2 diabetes mellitus may be found. Infertility, obesity, hyperandrogenism are the major complaints in this age group. And search for metabolic syndrome and type 2 diabetes mellitus in obese patients should be done. In the postmenopause age group, PCOS may be seen in ultrasound with mild androgen rise with metabolic alterations and type 2 diabetes mellitus. This includes androgen measurement in all women with the previous diagnosis of PCOS. This provides adequate reference values for androgens in the postmenopause age group. Ultrasound of ovaries may or may not be needed. It is questionable. And at this age group, great emphasis should be done on diagnosis of the cardiovascular disease risk factors in presence of hyperandrogenism. So, polycystic ovary syndrome with hyperandrogenemia and insulin resistance can lead to reproductive failure. It leads to follicular growth arrest and poor oocyte quality and also poor endometrial receptivity. Also, progesterone resistance is there. Even if we provide progesterone, it cannot lead to good decidualization or receptivity because progesterone receptors are more concentrated in the epithelium than in the stroma. Then neuroendocrine disorders may be seen as imbalance of hypothalamo-pituitary adrenal axis, hypothalamo-pituitary ovarian axis. Abnormal lipid metabolism may be seen with dyslipidemias, obesity, hypertension, non-alcoholic fatty liver disease, and sleep disorder breathing. So, coming to the metabolic syndrome. Metabolic syndrome, it affects almost 1/3 of the PCOS patients. Initially, there may be precocious puberty, and this with pediatric obesity, precocious puberty, increased insulin resistance, may have dyslipidemia, metabolic syndrome with pre-diabetes and diabetes symptoms. So metabolic syndrome risk factors include central obesity. So the waist-hip ratio may be more than 0.8 and waist circumference may be more than 88 centimeters, and also hypertension. This is because of the increased vasoconstriction because of increased sympathetic drive, increased sodium and calcium in the cells, and insulin growth factor 1 acting on the smooth muscle of vessels leading to hypertrophy, and also renin angiotensin system, aldosterone system may be activated in this. Atherogenic dyslipidemias also may be a risk factor for metabolic syndrome. Insulin resistance that may be seen genetically or because of the obesity and other factors also constitutes a risk factor. Then what is the consequences of this metabolic syndrome? So consequences include cardiovascular disease. This may be because of hypertrophy of the vascular muscle, hypertension, endothelial dysfunction, atheromatic deposits of LDL, and also platelet aggregation may be seen. Increased viscosity of the plasma because of the decreased fibrinolysis and plasminogen activation inhibition 1 system in these PCOS people. Type 2 diabetes may result endometrial. They are prone 30 times fold increase for sleep apnea syndrome. Psychological problems because of obesity and infertility, and also hyperandrogenism with hirsutism on the face. This may lead to low self-esteem, anxiety, and also depression.
Ma'am, can you please share your screen, ma'am, once again? Ma'am, we are not able to see the slides, ma'am. Now it's
వినపడట్లా, అంతా కనపడుతుంది కానీ పెట్టాను. మరి ఇప్పుడు ఎవరో ఒక మగాయన కనపడ్డాడు, మాట్లాడుతుంది అట్లా. అదే నా బాధ.
Ma'am, now we are able to see the slides, ma'am. You can continue.
జాయిన్ ఆడియో కొట్టాను, షీల్డ్ కనెక్ట్ 4 అని వచ్చింది. ఏందో
summary of obesity.
Ma'am, you are on mute, ma'am.
Coming to the summary of the mechanisms linking the obesity with PCOS. Obesity increases the adipokinin secretion with obstructive sleep apnea and insulin resistance. This leads to compensatory hyperinsulinemia and also ovarian androgen production and ovarian dysfunction, metabolic dysfunction, all leading to PCOS. Also androgen mediated lipolysis because of PCOS, and also mental emotional health. All these lead to obesity. and also genetic factors and energy expenditure may lead to obesity as well as PCOS. So, coming to dyslipidemia in PCOS. So, what is dyslipidemia? Dyslipidemia is a disorder of lipoprotein metabolism, including either deficiency or overproduction of lipoproteins. There is decrease in HDL-C and increase in LDL-C. So, studies had revealed that there are different degrees of obesity, dyslipidemias, insulin resistance, oxidative stress, and other metabolic abnormalities. And among all these abnormalities, dyslipidemia is most common phenomenon, and it is a connecting link between the metabolic syndrome and also the PCOS. So, PCOS patients, they show mild hypercholesterolemia and also lipid abnormalities. So, different lipid patterns seen in PCOS are increased triglycerides, increased total cholesterol, increased LDL-C concentrations with reduced high HDL-C concentration. So, how dyslipidemias and insulin resistance are associated? Approximately 50 to 70% of women with PCOS have insulin resistance, and they are 5 to 10-fold greater risk of developing type 2 diabetes mellitus in future. Up to 70% of women also have PCOS. So this insulin resistance PCOS and also dyslipidemias are similar with decreased HDL concentrations and increased triglyceride levels as in PCOS. So here we have to know what is adipocyte, how the adipose tissue functions. So first, adipose tissue, it consists of adipocytes surrounding vessels and also the monocytes that are seen in the adipose tissue. Adipocyte, it not only acts as a storage organ, but also it is metabolically active. It can secrete so many hormones and peptides. It can secrete adiponectin, dystatin, resistin, leptin, and angiotensin too. Adiponectin is protective and it has insulin sensitization increasing properties, anti-atherogenic, anti-inflammatory. Coming to leptin, it increases the insulin resistance. It leads to ectopic fat deposition as in liver, kidney, heart, and also pancreas. And it also decreases the dominant follicle granulosa cells to insulin growth factor 1 and leads to follicular growth arrest. Dystatin increases insulin resistance. Resistin also acts in the same way. Angiotensin 2 can increase hypertension. Then the status of these endocrine secretions, it depends upon the nutrition intake and also the energy spent. A study found that proportion of insulin resistant diagnosis were statistically higher in obese patients. Dyslipidemia is more found in PCOS with central fat. So the location of adipocytes in central fat, they have disadvantageous effect on plasma. So intra-abdominal fat accumulation, this may contribute to lipid metabolism disorder. The subcutaneous abdominal adipose lipids, they protect against insulin resistance in humans, but the intra-abdominal tissue has the opposite effect. So in the subcutaneous adipocytes, there is catecholamine and testosterone induced inhibition of the hydrolysis of the fats. So the cells only undergo hypertrophy. There's no proliferation of these cells. And so whatever excess fats that we take, will be mobilized to store in the intra-abdominal fat or in ectopic or fats in liver, kidney, and pancreas. So, intra-abdominal adipocytes, they are resistant to the anti-lipolytic action of the insulin. Normally, insulin has lipogenic action, but these intra-abdominal adipocytes, they are resistant to this action. So, they undergo lipolysis and they increase the circulation of free fatty acids in the portal system. They are carried to the liver. In the liver, they lead to increased glucose levels by stimulating gluconeogenesis. And also the free fatty acids increase can lead to formation of VLDL and triglycerides. Also, these can decrease the SHBG production in the liver. In the muscle, the increase in free fatty acids, they can lead to insulin resistance by serine phosphorylation of the beta unit of the insulin receptor and lead to decreased glucose uptake. Thus, all these lead to increase in the glucose levels. In turn, the insulin levels. Also, LDL concentration is increased and HDL concentration is decreased, and this leads to dyslipidemia and also hyperandrogenism status. Coming to dyslipidemia and hyperandrogenism. Hyperandrogenism is a vital feature of PCOS patients. A previous study reported that there were no associations between diethylamine and testosterone. In addition, studies have shown that HDL levels are lower in PCOS patients without hyperandrogenism. Abruzzi, G.A. et al. Found that all PCOS patients, independent of their androgenic condition, showed a high metabolic risk. So, androgen is bad for lipid metabolism, while dyslipidemia does not directly affect metabolism in PCOS. Gombal, C.S. et al. Found liver fat to be tightly related to hyperandrogenism and adverse metabolic profile. So, even the adipose tissue, it consists of 5-alpha reductase. This converts testosterone to more potent 5-dihydrotestosterone. This leads to hirsutism and also increased catabolism of cortisol. This in turn leads to increased ACTH and increased adrenal cortex drive and increased androgens. Thus, adipose tissue increase can lead to hyperandrogenism. Then, these findings suggest that hyperandrogenism is associated with fat distribution. Also, apolipoprotein A1 levels are directly related to the number of transcripts of steroidogenic enzymes in ovarian granulosa cells. So, also, there is reduced CYP90 expression when a apolipoprotein A1 depletion occurs. This increases the level of testosterone. Being impaired conversion to estradiol is observed in PCOS patients. So, adipose tissue, a source of pro-inflammatory cytokines, it has the capability of secreting angiotensin to stimulate the NADPH oxidase activity. Further produces more of reactive oxygen species in adipocytes. Also, free fatty acids in PCOS stimulates NADPH oxidase expression and subsequent ORMOS generation, further promoting insulin resistance in obese people. Also, pro-inflammatory C-reactive protein, this TNF-alpha, interleukin 6 are secreted. TNF-alpha secretion increases the insulin resistance and also increases interleukin 6 production. This interleukin 6 It inhibits the lipoprotein activity, increases aromatase activity, increased production of triglycerides in liver, and also stimulates C-reactive protein. This C-reactive protein in turn leads to obesity, insulin resistance, and endothelial dysfunction, of which high sensitive C-reactive protein is a marker. Thus, TNF-alpha and interleukin-6, they are associated with atherosclerosis, dyslipidemia, and hypertension, resulting in cardiovascular disease and also cerebrovascular disease. So, how dyslipidemias are associated with anovulation? So, the anovulated PCOS, they have increase in total cholesterol levels, triglycerides, LDL cholesterol, and decreased HDL cholesterol. Obesity can lead to dyslipidemias, and this can lead to anovulatory and irregular cycles. Increased triglycerides, free fatty acid concentration, ox-LDLs in serum can lead to mitochondrial dysfunction by increased production of the reactive oxygen species and can lead to follicular atresia and ovarian damage. So, ox-LDL receptors like LOX1, TLR4, CD36, this activation can lead to apoptosis of the human granular substance and disorder ovulation. In addition, abdominal obesity stimulates ovarian and adrenal androgen production, also reduces the SHBG levels in PCOS. So, high levels of testosterone may further increase abdominal obesity and inflammation, creating a vicious cycle. Dyslipidemias and anovulation. So, increased LDLs and glycerol and lipids, cholesterol, and increased free fatty acids like amytolic acid and linoleic acid. All these are detrimental to the growth of the follicle, and this lead to infertility. So this slide shows the summary how the dyslipidemia affects PCOS patients. So increased monocyte to HDLC concentration can lead to inflammation and PCOS. Increased free fatty acid concentration can increase the monocytes, inflammatory cytokines, and then inflammation leading to PCOS. And increased NADPH oxidase activity increases ROS. This leads to insulin resistance and then PCOS. Then apoprotein A1 concentration decrease can affect the expression of these enzymes for conversion of testosterone to estrogen and leading to hyperandrogenism in PCOS. Ox-LDL secretion can lead to mitochondrial dysfunction and ROS formation with follicular atresia, ovarian damage, and anovulation. So, coming to the treatment of the dyslipidemia, this includes lifestyle management and also lipid-lowering drugs. So, lipid-lowering drugs are of three types. They are statins, omega-3 polyunsaturated fatty acids, and nicotinic acid. So, statins can reverse all the changes that are seen with dyslipidemias and bring about improvement in PCOS. Statins, they are commonly used to treat PCOS patients to reduce inflammation, oxidative stress, hyperandrogenemia, and other metabolic parameters. Statins can inhibit the HMG-CoA reductase, in turn reduce the concentrations of mevalonate. This is the substrate for cholesterol synthesis. Thus, it improves the lipid metabolism, inflammation, and hyperandrogenism. So, even improvement in this dyslipidemia status can also improve the insulin sensitivity. So, coming to action of statins. After giving atorvastatin, there is increase in 25-hydroxy vitamin D concentration with decreased HSCRP and improved menstrual symptoms in PCOS patients. Generally, MDA malondialdehyde and testosterone concentrations, malondialdehyde concentrations, and oxidative reactive markers can increase the levels of free testosterone. So, while MDA levels are reduced, all these testosterone, total and free testosterone can be reduced, and this alleviates hyperandrogenism, inflammation, oxidative stress, and other lipid abnormalities in the PCOS. So statins like atorvastatin, simvastatin, lovastatin, they are the most common statins used. These can inhibit the DNA synthesis in the follicular mesenchymal cells and thus inhibit the proliferation of the theca cells. Also, these reduce the expression of the CYP17A1 and reduce the uh, production of androgens in the theca cells. Thus, this simvastatin and other statins can improve the menstrual symptoms and hirsutism, acne, and ovarian volume also. So, increase in homocysteine levels can increase insulin resistance and also levels of increased testosterone and free testosterone levels. So, on treatment with atorvastatin and simvastatin, these can reduce the testosterone and free testosterone levels by increasing the activity of the liver cystathione B synthase and shifting the homocysteine to transsulfuration pathway and thus improves insulin resistance and hyperandrogenism in Pcos patients. Coming to the omega-3 polyunsaturated fatty acids, this alters the transcription of peroxisome proliferator activated receptor B, sterol regulatory element binding protein 1, carbohydrate regulatory element binding protein, max-like factor X heterodimer. So omega-3 fatty acids, naturally they activate the PPARs. This inhibits the lipid synthesis in the liver. PPA gamma regulates the expression of several genes that encodes protein in adipocyte differentiation and also fatty acid storage. Omega-3 polyunsaturated fatty acid supplements for 12 weeks can improve the expression of PPAR gamma gene and LDL receptors were reduced by PI3K or PKB pathway and also modulation of the activity of the oxidase stress induced nuclear factor K gene binding pathway in PCOS. So omega-3 fatty acids like icosapentaenic acid, this can upregulate the IGF-1 expression in the PCOS patient, thus leads to formation of the dominant follicle and also its maturation, thus improves fertility. And this action is more pronounced with combination with recombinant FCH. So with 6 months treatment of these omega-3 fatty acids, they reduce the LDL concentration, increase the HDL concentration, they reduce LH, total testosterone, and free testosterone, also increase the levels of SHBG and thus improve insulin resistance, inflammation, hormonal profiles in PCOS. Coming to the nicotinic acid, it is a part of coenzyme 1 and 2. So niacinic acid in the form of nicotinic acid binds to the nicotinic receptors in the adipose tissue and it inhibits the hydrolysis of the triglycerides. This reduces the circulating non-esterified fatty acids into the liver and thus decreases the hepatic synthesis of DLDL and triglycerides. Also, nicotinic acid improves lipid profile by lowering the LDL-C particles and increasing HDL particles in serum of PCOS patients. So, coming to the lifestyle management. So, current lifestyle modification is weight loss of at least 7% of the body weight, increased physical activity at least 150 minutes per day, a 500 to 1000 kilocalories per day decrease from usual diet, 1 to 2 pounds weight loss per day, low calorie diet of 1000 to 1200 kilocalories per day, achieving about 10% decreasing of total body weight in 6 months. Reduction in weight by 5 to 10% of the initial body weight may reduce the levels of insulin and androgens. Weight gain recurs when the lifestyle modifications are not successful. We always see the patient asking for medicines, but they don't listen to the lifestyle management what we teach in the hospital. So lifestyle modification programs, they have been associated with poor levels of compliance. Very low calorie diet can lead to poor oocyte quality. Also, metformin given in 850 mg twice daily cannot show any effect on the menstrual frequency, body weight, insulin sensitivity. But there is a fall of total testosterone levels and also the weight circumference. Only statin PCOS obese shows a degree of effectiveness. However, there are no large randomized trials in obese subfertile women. So myoinositol treatment increases the serum plasminogens and decreases the small dense LDL part, particularly in hyperlipidemic patients with metabolic syndrome. These results suggest that increased plasminogen biosynthesis and low serum levels are especially effective in improving the metabolic syndrome among hyperlipidemic subjects with metabolic syndrome. Coming to the screening for cardiovascular risk in PCOS, CVD risk factors may include obesity, lack of physical activity, smoking, family history of type 2 diabetes, dyslipidemia, hypertension, type 2 diabetes mellitus, and impaired glucose tolerance. So in late reproductive age and menopause group, as the age increases, there is increased insulin resistance, increased abdominal adiposity leading to increased waist circumference, dyslipidemias, and also chronic inflammation. So normally, these all metabolic syndromes may be seen by the age of even 30 to 40 in late 30s or 40 to 50 age group. And women with PCOS, they demonstrated a prevalence of type 2 diabetes mellitus of 39% as compared to 5.8% in the general population in the West. So overall summary of this session is polycystic ovarian syndrome showing insulin resistance and hyperinsulinemia with hyperandrogenism may lead to obesity, and with traditional risk factors of the metabolic syndrome like central obesity, dyslipidemia, hypertension, impaired glucose intolerance can lead to metabolic risk factors like hyperandrogenism, sympathetic nervous system dysfunction, ovarian chronic inflammation, oxidative stress, hemostasis, and fibrinolytic imbalance, vitamin D deficiency, mood disorders, gut microbiota data dysbiosis, and with epigenetic alterations. This can lead to premature atherosclerosis by endothelial dysfunction, intimate media thickness, coronary artery calcification, and all these lead to cardiometabolic diseases like non-alcoholic fatty liver disease, type 2 diabetes mellitus, coronary heart disease, and stroke. So, after explaining everything, I can conclude that the combined therapy of myoinositol plus D-chiro-inositol in 40:1 ratio is able to improve the metabolic profile of the PCOS woman and therefore reducing the cardiovascular risk. Thank you. Hope you have a nice session. And thank you, Sheel, for giving me this opportunity. Thank you.
Thank you very much, ma'am, for the wonderful presentation.
Welcome.
It was very honor and learning to hear you, ma'am.
Thank you, sir.
Yeah, ma'am, if you allow me, then we'll take the questions.
Okay, sir.
Yeah, sure, ma'am. Ma'am, we have a first question. That is, can PCOS?
Display.
Hello.
Sir, just let me have the display of this question. Question is the display of this.
Ma'am, questions is in the another window, ma'am.
Okay, sir. Just tell me, sir.
Yeah. Can PCOS be a cause of primary amenorrhea?
Yes. Yes. Increased adrenarche. Also, even before onset of menstruation itself, can cause amenorrhea. I have seen certain cases, and when I gave them progesterone, I have done scans for them, and just I saw PCOS, just endometrium with hyperplasia, and then I have given them progesterone. They attain menarche. This is possible.
Thank you, ma'am.
Okay, sir.
Yeah. Ma'am, we have one more question. That is,
Okay, sir.
what is the percentage of PCOS patients can have GDM in future?
So already it's a GDM is almost five-fold increase when they have this impaired glucose intolerance. Five-fold increase than normal people.
Yes, yes, ma'am. Thank you, ma'am.
Yes, sir.
Ma'am, we have one more question. That is, can be a bariatric surgery can reduce the risk of dyslipidemia and PCOS?
Yes, certainly. Bariatric surgery can reduce, but bariatric surgery is offered when the BMI is more than 35 or with 30 with any metabolic disorder only, and mainly in infertility or also in the old age group. This is certainly advised, and this can lead to improvement in the dyslipidemia.
Thank you, ma'am.
Yes, sir.
I think we have one more question, ma'am. That is, how to manage a lean PCOS patient?
Lean PCOS, here the intra-abdominal visceral fat is more. Subcutaneous may not be there also, but here the insulin resistance is more. That insulin resistance is because of the GI increased intake of the saturated fatty acids that can lead to increased leaky gut. So beta lactamate supplementation can lead to alleviation of these symptoms in lean PCOS. So increased intake of omega-3 polyunsaturated fatty acids and also beta lactamate supplementation is more important in lean PCOS.
Thank you very much, ma'am. I think there are no more questions from the delegates, ma'am. If you allow me, then we can close this webinar.
Okay, sir.
Yeah. Thank you very much, ma'am, for the wonderful presentation and for your
Welcome, sir.
valuable time. We look forward for your continuous support for this educational initiative. Thank you very much, ma'am.
Sure.
And also thank all the delegates for their active participation.
I thank the Shield to giving me this opportunity. Thanks a lot.
Yeah. Thank you, ma'am. And many thanks from the Shield team. Thank you, ma'am.